And welcome very much to this Medical Media Holdings program this evening entitled Novel Treatment Options for Multiple Myeloma. It's absolutely a joy of mine to be able to kick off this program with three extraordinary myeloma experts who also happen to be good friends of mine, but don't hold that against them, please. Great people that are joining me this evening, as you can see from the slide here. My name is Joe McHale. I'm a professor at the Translational Genomics Research Institute and the Chief Medical Officer of the International Myeloma Foundation. With me today is Dr. Joshua Richter, who's an associate professor at Mount Sinai. Thirdly, we have Dr. Ed Stadmauer, who is a well-known expert in the field and has been for many years as a distinguished professor at the University of Pennsylvania, who has been sentinel in many of the developments of cellular therapies in myeloma. And Dr. Nina Shah. Nina is a professor of clinical medicine at UCSF, and she'll be joining us a little bit later as we get further into this topic. So you can see the accreditation information here. I won't go through it in extensive detail, apart to say that as a healthcare professional, whether you are a physician, a PA, a nurse practitioner, there is an opportunity for you to obtain CME credit for this program, and it is in keeping with our accreditation standards. We would like you to know that this is going to be available to you until August 22nd, in keeping with typical CME and CE. We would like you to fill out the evaluation form at the end, and more instructions will come at the end for that. So for this period of time that we have together over the next couple of hours, our learning objectives are as follows. We want to identify the benefits and risks of frontline therapy for multiple myeloma, summarize the role of sequencing therapies in relapse and refractory multiple myeloma, which is always a hot topic, assess the optimal combination therapies for myeloma, appraise the advantages of CAR T-cell therapy, and we're going to talk a little bit more about different modalities of CAR T-cell therapy in relapse refractory myeloma, and then how do we incorporate other novel agents, primarily the monoclonal antibody drug conjugates, the ADCs, and indeed the bispecific therapies. So we're going to cite the efficacy and safety of bispecific therapies that target BCMA. We're focusing primarily on the BCMA target, although, as we're going to hear, there are many other targets being developed with time. So just to get us warmed up and to get you thinking a little bit, I'd like to share with you a case. I'm going to be focusing a little bit more on the diagnostic side of things in myeloma, not as so much the therapeutic side of things. So this is more on a diagnostic question. So this is a patient who's 6 years old, type 2 diabetes, presented to the emergency room with progressive left-sided chest pain over 3 months. And this pain had been happening, obviously got a lot worse, that led them to the emergency room. The cardiac workup was negative, but a CT of the chest demonstrated a large lytic lesion involving the left lateral fifth rib, and there was soft tissue extension of the mass. Numerous lytic lesions were seen throughout the spine, ribs, and sternum. I mean, obviously, this is a program on myeloma. If you haven't figured out it's myeloma yet, yikes. But nonetheless, the further workup revealed the patient had a normal albumin, a normal beta-2 microglobulin, a creatinine of 1.3 slightly elevated, but a normal serum protein electrophoresis, and a bone marrow revealed 30% plasmacytosis. So you've got a few key things here, but there are a few potentially things missing. So on the diagnostic side, what critical tests would you still require for an appropriate risk stratification of this patient? Because I'm going to be sharing with you some thoughts about how we risk stratify in multiple myeloma. So we need to do conventional cytogenetics, serum free light chain testing, and LDH and FISH testing on the marrow. Do we need to do LDH, serum free light chain testing, FISH testing on the marrow, just FISH testing, or LDH and serum free light chain testing? We're going to talk a little bit about these as we go through this part of the talk. So I'll give you a chance to answer. What critical tests would you require? Is it A, B, C, or D? And we'll give you time to look through it and make your selection. So do you want conventional cytogenetics or not? Do you want serum free light chain testing or not? Do you want FISH testing or not? Hopefully that will help you think through this case a little bit together. So we'll give you a little bit more time. I'm being a little controversial in this because I'm going to suggest that some of the old school testing we may not always be doing, but I don't want to give away my cards here, so I'll let you think through it a little bit longer and then we'll see where we are for the answers. I do mention this, by the way, because inevitably we often get referred patients where significant important testing has not been done. So I do think this is clinically relevant. Oh, and I don't know if we can see the results here, but we're going to have a look at this again after the evaluation. So make sure you submit your answer here. We will, we're getting a little feedback here. We'll just wait for that to pass, and then we're going to get into our next slide. So I've been given the task to think a little bit with you about risk stratification of myeloma, how we test for it, and what clinical implications are there. So I don't want this just to be a boring, this is how I test, this is what I do. We want to make it relevant clinically. So for my conflict of interest, I have served as a consultant for these companies listed here. So what are my objectives for the next 15 to 18 minutes that we're going to spend together? We're going to review the staging of myeloma and the heterogeneity of this disease. And then I really do want to introduce the importance of risk stratification. I'm going to suggest to you, in fact, on multiple occasions that myeloma is not one disease, but in fact is many. And then pragmatically, for the treating clinician here, think a little bit about how do we deal with this risk stratification? Is it just an academic test? Is it just theoretical? Or do I actually do something differently because my patient is high risk or standard risk? So as I'm sure you all know, we changed the definition of myeloma almost 8 years ago, whereas historically we always said you have CRAB criteria. Show me the CRAB: calcium elevation, renal insufficiency, anemia, or bone disease. But now we've added 3 more to what we sometimes call the slim CRAB criteria, so 60% plasma cells and a light chain ratio, or at least involved over uninvolved light chains of greater than 100, or if an MRI is done of the marrow, more than one focal lesion. And this is a function of the fact that typically a marrow should be homogeneous, but if there are focal areas, it tells us more about focal disease. So in a sense, we've broadened already the diagnosis of myeloma, not just the presence of end organ damage, but these 3 new phenomena are sort of pointing us towards the fact that we are soon to have end organ damage. With that much plasma cells, there's inevitably going to be damage. With light chains being that high, there's going to be renal insufficiency. With an MRI finding like that, it's likely speaking of bone damage to come. And so now we've slightly shifted the historical 3 pillars of MGUS, or monoclonal gammopathy of undetermined significance, smoldering myeloma, and active myeloma, and so pulled a little bit out of smoldering and pushed it into true myeloma by having any of these 7 myeloma-defining events, along with the 10% plasma cells and a monoclonal protein, as you see here. So historically, we've staged patients with the ISS criteria, where basically we just take a serum beta-2 microglobulin and an albumin, and based on those 2 numbers, we can come up with a staging system. But what I'm going to be sharing with you a little bit more today is about how we've advanced that in this new a revised staging system to now include cytogenetics, which really makes sense because although, no disrespect to our friends serum beta-2 microglobulin and albumin, they're important players, but the cytogenetics actually likely tell a greater story. And so initially, the 3 key cytogenetic features that were mentioned are deletion 17p, 414, and translocation 1416. And notice that we need FISH testing to do this. We don't actually really need conventional cytogenetics. Going back to our question from earlier, I would suggest that conventional cytogenetics, although it may be academically of interest, is not particularly important in our modern risk stratification process. Now, some places still continue to do it, but thinking about the case that we designed, I definitely need the light chain testing, as I'll show you in a moment. We definitely want the FISH testing so that we can help this new revision. And this revised ISS is important not only because it divides people into 3 categories, it clearly has an impact on overall survival. So you can see those patients here that had stage 1 disease in the blue line had dramatically better outcomes than those that had stage 2 and at worst, sadly, stage 3. Now, granted, since this time, this being published several years ago now, we have seen an improvement in overall survival in all 3 groups, by virtue of novel treatments, and nonetheless, it still divides. And part of this is a function of the fact that myeloma is really not one disease. I mean, perish the thought to our lymphoma colleagues if I just said, oh yeah, I treat all lymphoma the same way. I mean, there's 30 kinds of lymphoma, which I think is sort of a way to keep a lymphoma pathologist busy. But we actually similarly have multiple types of myeloma. Now, I didn't put this up to go through in a lot of detail, but just to show we have multiple different genes mutated. This isn't a simple Philadelphia chromosome positive CML kind of situation where there's basically one mutation with some submutations. Here we have multiple pathways affected, and you can see that the frequency is such that there really isn't a dominant mutation. We do see KRAS and NRAS mutations in many patients, and even a P53 mutation, which we often talk about, but these aren't dominant, but tells you again of the heterogeneity of multiple myeloma. If you don't want anything to do with the biology per se, and you're just a pragmatic clinician, then I would also argue that myeloma is not one disease. We have people like this green line. They get treated maybe with their induction therapy and maintenance, and they remain in remission for a long time, relapse slowly. More often than not, we have patients like this blue line where they get into remission, but it lasts a bit shorter. And sadly, with each relapse, the remission gets shorter. And then lastly, and sadly, we have patients much like this high-risk patient who I saw in clinic today, essentially, that had this situation where they may have gotten an initial response, but it just seemed every time we treated them thereafter, their disease became rampant. And that is really a tragedy. And one of the things that we want to be able to do better for these patients in providing them more options. So another way of picturing this is that we know, biologically speaking, that clones change over time. And this helps us appreciate the fact that the disease acquires mutations. It evolves over time to become more aggressive. And so I know that my colleagues in a few minutes are going to be talking to you about frontline therapies. And as we listen to that, which I know will be riveting lectures, I enjoy listening to these folks speak, they're going to share with you that what you do early in a myeloma patient's treatment actually affects the long term. And so it becomes very important what we do early on. Just to give you one example, this is an individual patient. I know it looks a little bit confusing, but there's two key lessons I want to show you through this patient. This is a patient that we published about almost 10 years ago, a very interesting phenomenon where this patient had IgA myeloma, and you can see in red their IgA level. They went into a deep remission, stayed there for a long time, and unfortunately started relapsing quickly. But interestingly, at the end, their IgA level didn't go up anymore. By contrast, in blue, we have their light chain level that initially was not elevated, but then became elevated at the end. And sometimes we refer to this as light chain escape. There's clearly been a biological change in this person. This is one of the things that reminds us, remember that 20% of patients only have light chain disease, and so it's very important to obtain the light chain. This same patient actually, I won't bore you with the methods that we used here, we ultimately determined this actually patient had multiple different myelomas within the same person, if you will, multiple clones. And at different times in their myeloma career, sadly, different clones became dominant. And sadly, she ultimately died of this blue clone that was barely visible at her diagnosis. So myeloma is a very dynamic disease, is really the bottom line here. And it's important for us to not let it get out of control. It's important for us to understand that heterogeneity. So why would I even bother risk stratifying? Well, it affects prognosis. It may affect clinical trial selection, as we have trials that now focus on certain cytogenetic abnormalities. And really, the holy grail standard here is, does it affect therapy? And the rationale, of course, is that we may be able to use less in certain patients. I know that in the myeloma world, we've all been about more is better. We went from doublets to triplets to quadruplets to single maintenance therapy to double maintenance therapy. You know, it seems like as a myeloma doctor, you have to look at your patient and say, you'll take it and you'll like it and you'll ask for more. And that's not what we want to do. We want to be able to find a way. And there are some very interesting trials now looking at stopping rules for patients. But we already are doing some degree of risk stratification. We know that patients with translocation 414 seem to be more responsive to proteasome inhibitors. We know that patients with translocation 1114 tend to be more responsive to venetoclax. And we know that patients with a P53 deletion likely benefit from proteasome inhibitors, whether it's bortezomib or other, for longer periods of time. The concern, of course, is if you take the risk stratification too far, you could undertreat standard risk myeloma by thinking, oh, I'm only going to more aggressively treat high risk myeloma. But we have to be careful. The total therapy experiment demonstrated that even in the most intense therapies, we're not curing a large fraction of patients, although I think that fraction is increasing. And so we have to strike that balance, and that's what becomes difficult. I hope I'll help you as we go through, because the inevitable reality is with more and more lines of therapy, fewer patients are eligible for treatment. So when we think about how we risk stratify, as I've mentioned here on the right, I have the revised staging system again for you, but I've added on the left here, since we've devised the RISS, we've come across two more cytogenetic abnormalities that influence. Excuse me, and they both involve the chromosome number 1. On the Q arm of chromosome 1, if we see a 1Q gain, and in particular if we see 4 more copies, if we reached an amplification status, that's clearly high risk. If someone just has some 1Q gain, it's still up in the air, I would argue, a little bit as to what that really means. And then we've seen that the 1P deletion is also an adverse prognostic marker. And historically, as we detect myeloma, of course, we do it through the classic serum protein electrophoresis, and we do it through the serum-free light chain measurement. And this was a reminder for me to tell you, don't forget to check light chains every time you're monitoring your myeloma patient. As I mentioned, 20% of people have light chain-only disease. Because if we only involve one, we're not going to have nearly the degree of accuracy in diagnosing and following this disease. But we also not only look at the absolute light chain levels, the both involved and uninvolved, we look, of course, at the ratio, because that's what speaks to the clonality. If you see a patient like I saw today who is on dialysis for the renal dysfunction, well, both their kappa light chain and their lambda light chain are elevated. So the ratio becomes more important in determining the clinical significance of that. And I wrote this editorial a couple of years ago, being a little tongue-in-cheek about it. Pee no more, urine light chains down the drain. There is still a role for urinary testing and 24-hour urines nonetheless, but please remember how important it is to measure the light chains in the serum. And if I were to become prophetic for just a minute or two, I would say that in the future, it's quite likely that we will replace our serum protein electrophoresis and light chain testing by mass spectrometry, where we can actually detect down to the exact Dalton, the weight of those proteins in a patient's serum, to know exactly what their M spike is, and to know, is this the M spike that's coming from their drug, or is this the M spike coming from this disease? Is this the M spike that they had before, or like in the example I gave earlier, has the disease evolved and now created a new M spike? But again, that's just for future considerations. And as we think of this through, I can't help but share a few thoughts about minimal residual disease, because now we've reached a point with these great therapies that you're going to be hearing about in a few moments. We have a greater opportunity to get people into very low-level disease. And so historically, response is anything that is greater than a 50% reduction in the tumor. But now we're able to get all the way down into CR and even stringent CR as we get further, if you will, under the water below that, as the iceberg that you see here in the water. And why is this important? Well, here's just one study from a group of Spanish frontline studies showing that even if you compare those patients that achieved a complete remission but not MRD negativity, they don't do as well in the long run as those who are MRD negative. So the light green line here represents progression-free survival and overall survival in patients who achieved MRD negativity. Now, again, I go back to my point about heterogeneity of myeloma. Not every single patient needs to achieve MRD negativity, right? Again, we don't look at the patient and say, you're going to get to MRD negativity and you're going to like it. I mean, there are paradoxically some patients who do very well long-term who are never achieving this depth of response. But in general, especially in some low-risk patients, if you will, in particular those who are hyperdiploid, but in general, we are trying to achieve that. So that deeper response, that last bit of disease is often the most resistant, isn't it? Rambo is the last soldier to be killed, right? There's that last bit of most resistant tumor that we want to eliminate. And that's why MRD status is now even influencing the way we think about how we stratify disease. So to be more specific in my last few slides here, how do I then define high-risk disease? Well, We roughly estimate that somewhere around 25% of patients with newly diagnosed myeloma will have high-risk disease. This fraction increases over time, as I've mentioned, as patients acquire mutations. And it's interesting that sometimes you can't tell that by their initial therapy. Paradoxically, some people actually respond really quickly with high-risk disease, but then their disease comes back quickly. I tell my patients, it's like high-risk disease has more horsepower. It just has that ability to regrow more quickly. And often is still responsive to therapy. But there's really multiple ways of defining. As I've shown you, there's the ISS criteria, the revised ISS criteria, the IMWG is added criteria. Now we can pragmatically look at things like plasma cell leukemia or extramedullary disease. All of these things speak to high-risk disease. And then pragmatically, if a patient is, if you will, behaving high risk, they've relapsed within a year of transplant, they're relapsing very quickly. All of these things push you into that way of thinking, this patient's at higher risk disease. Now, why do I want you to think about someone with high-risk disease? Because I'm going to suggest that actually influences how you treat them, that you have to be even more aggressive in that high-risk phenomenon. So in the old days, as I mentioned, we focused on these three high-risk phenomena, 414, 1416, and the deletion 17p. But now we've had to add many more, which include, on the left here, the 1Q gain that I've mentioned, and even hypodiploidy, knowing that by contrast, hyperdiploidy tends to confer a better prognosis. So lastly, on the highest risk standpoint, before I tell you how I approach high-risk disease, was this most aggressive form of myeloma, potentially what we call double-hit myeloma. I know people have used the word double hit for different things, but the Arkansas group actually first generated this phrase where they looked at a large group of patients and ultimately identified a group of patients that had more than 3 copies of that 1Q that I've mentioned, the CKS1B gene, at 1Q21 and ISS stage 3. That's a small group, about 5 to 6% of myeloma patients, but those patients had a sadly dismal outcome with an overall survival of less than 2 years. So it reminds us that we have an extreme in myeloma. We have a small group of patients that are going to live over 20 years, almost no matter what we do. We have at the other extreme a small percentage of patients that tragically have a horrible outcome, almost no matter what we do. And then there's the majority of the patients in the middle of the Oreo cookie, as it were, where everyone will likely have a better outcome if we take the therapeutic approach that we're going to hear about in a few moments. So there are many definitions, but I always try to be more inclusive by saying that it is really important to look at all of those features that can contribute to high-risk disease. Historically, most of us will use the RISS, include key cytogenetic abnormalities, now that we've added chromosome 1. Also, any other clinical features, as we mentioned, plasma cell leukemia, extramedullary disease, or relapsing within a year of transplant. So if you've been not listening to me for the last 23 minutes, just wake up for this one little bit here. This may be the most important thing I say about approaching high-risk myeloma, which is I'm going to suggest at least 4 principles. 1, combination therapy. Typically, we want to have more than one mechanism of action leveraged together. May or may not include a proteasome inhibitor, as I put in point 4 as a question mark, but at least some degree of combination therapy. So typically, these are not patients where we're very comfortable giving 1 or 2 drugs. Number 2, continuous therapy. These are patients where we even have recent data presented just at ASH from our friend Luciano Costa, showing that those highest risk patients may not be able to stop therapy early on. We hope that we'll develop better stopping rules for them. But with the conventional therapies and even some of the novel therapies we have now, that's a challenge. And then number 3, as I mentioned earlier, MRD negativity is a lofty goal in all patients, but in the high-risk patient, it's particularly important. When I was at Mayo Clinic, we tried to look at sort of the long-term survivors of myeloma, those people that lived over 15 years. And I was interested in those who lived over 15 years that never achieved a complete remission. A pretty small fraction of about 10 to 15% of long-term survivors. And interestingly, none of them, of course, were high risk. And the overwhelming majority of them had hyperdiploidy. So there's something special about that lowest risk population. But in general, we're trying to seek an MRD negativity. So in conclusion, myeloma is a complex disease. I tell my patients it's like a crime scene. You don't have one piece of evidence that gives away the whole story. You need multiple bits of evidence that requires careful testing and monitoring. For the clinician here today, please remember we need the serum protein electrophoresis and the light chain assay in your routine following of patients. Urinary light chains are not particularly, the light chain assay from urine is pretty useless. 24-hour urines can be valuable. Most patients are followed, as we said, with that, but you don't forget the light chain measurement. Staging has a lot to do with cytogenetics now than just beta-2 microglobulin and albumin, although they still remain important. And please don't forget those chromosome 1 abnormalities. Although I can still argue that MRD testing is not changing our immediate therapy, it is playing a greater and prominent role in myeloma and may likely influence our treatment in the near future. And we really have to have a more intensive approach in those patients that have the highest risk disease. It's a privilege to be a part of the world myeloma community, as it were, and I'm hoping, knock on wood, that with what's happening with the pandemic, we'll be able to start traveling a little bit more and see our colleagues in person across the planet as we try and take down this disease. So before I depart and hand it over to my good friend and colleague, Sir Joshua Richter, let's go back to that now as a post-test, that clinical vignette that I'd mentioned before. So here's a 60-year-old patient with diabetes, comes in, clearly has myeloma with this mass in their chest and lytic lesions. So far you have an albumin, a beta-2 microglobulin, a creatinine, a serum protein electrophoresis, and a marrow that just shows 30% plasma cells. What other critical tests are appropriate in making the risk stratification for this patient? What other features are you going to need here? And I'll let you have a look at these answers and give you a moment to answer before I pass it on to the boss. Okay, we'll give you a few more seconds for the masses to answer. Oh, thank you for letting people make their choice here. And let's see. I don't see the results yet, but I think we may get them shortly. If not, it'll be an exciting mystery to discover later, Josh, and I'll turn it to you in just a second here. We'll give people a few more seconds because I know there's a little time lag. And I will be clear that I do not have any conflict of interest with Oreo cookies, despite my use of them in the talk. I have no stock in said company. Okay, so answers are coming up. Some of you chose conventional cytogenetics, serum free light chain testing, LDH, FISH testing on the marrow. Honestly, I would accept A, although my point was trying to make that I would actually go with B, which is what the majority, almost 60% of you went with. I'm not saying the conventional cytogenetics are bad. They're just not as influential as they were before. They can help with certain phenomenon, but in general, it is now accepted that if we do FISH testing on the marrow, and this patient for the RISS was still missing the LDH, as I mentioned, it's important to know their light chain assay. So very well done. Nobody went with the other two at the bottom, so fantastic answers. And at this point, I will turn it to you, Joshua, to carry us through into part 2. Thanks so much.
Thank you very much. A brilliant, brilliant presentation as always. Thank you. And moving on to the next topic, which is going to be the relapse and refractory space of myeloma, which to me is absolutely the most fascinating. So here's our pre-test clinical vignette. 64-year-old male with a history of IgA lambda, multiple myeloma, Dury salmon stage 2A, fish showing in a translocation 1114, initially receives RVD, followed by stem cell transplant, develops persistent grade 1 neuropathy from the treatment with bortezomib. He opts for no maintenance therapy. However, 3 years after transplant, develops a biochemical relapse. Which regimen offers the best data to date in this setting? So we have our options of VRD, IRD, DRD, XVD, or belantamab mafodotin. And I'm going to give you a few minutes, not a few minutes, a few seconds in the ballpark of 30 to kind of ponder some of the data out there. And we're going to review some of the data in just a moment, but really trying to put on your thinking caps of if this patient walked into your clinic, how would you approach them? And, I think that, myeloma is kind of the wild, wild west still. There's so many different options of what we can do. The question is, how would you put this one together? Got about 10 or so more seconds-ish, I think. I love live dead air. It's just so awesome. So you guys heard the one about the 2 peanuts that were on the subway. One of them was assaulted. Okay, horrible dad joke. And with that, I think we're going to move forward because I don't think we get to know the answers up front. And we're going to talk about combination options for relapse refractory disease. I have lots of conflicts. I get around the conflict by working with everyone. So how do we choose therapies in myeloma? And one of the big things is myeloma is, there's a bevy of different options. I'm so sorry that this keeps flipping out, that we have in the relapse refractory setting. And what we know in 2022 is 1 drug is better than 0, 2 is better than 1, 3 is better than 2. And in the upfront setting, we have a few studies showing that 4 is better than 3. But for the most part, 3 is really the place that we've settled for the majority of approaches in the relapse setting. And when we say 3, it's 1 drug per category. We don't kind of do 2. We don't have a lot of regimens that give daratumumab and elotuzumab. And one of the drugs is almost always a steroid, most commonly dexamethasone. And we pick an IMiD, a proteasome, and a steroid, or an antibody, a proteasome, and a steroid, et cetera, et cetera. And these are some of the main therapeutic options. And the ones on the left are very familiar, where people are very comfortable using drugs like lenalidomide and bortezomib, and even drugs like cyclophosphamide. And as we move to the right, we get to some drugs that may be used a little bit less commonly, like elotuzumab, selinexor, belantamab. And last on the list is Abecma, which is idacaptogene viclucil, the CAR T-cell therapy that was approved last year. I put it in red because I don't understand enough about it. But thank goodness we have people like Ed Stadmauer and Nina Shah who are going to talk about it shortly. So I'm really going to have that there as a potential option, but not what we're going to focus on for what's commonly available in the clinic setting. So how do we actually choose when we have all of these drugs? And really what it comes down to, at least in the clinic, is we base our decisions on 3 different dimensions: patient-related factors, disease-related factors, and treatment-related factors. Yes, we know that some patients are high risk and some are standard, but we don't yet have the granularity to know which specific drug for which specific patient. There is definitely evidence that 414 does better with proteasome inhibition and 1114 for venetoclax, but for the majority of treatment decisions we're making, we're looking at these 3 dimensions. So is your patient old or young? Fit or frail, many comorbidities or none? Their disease, is it a biochemical relapse or is it a clinical relapse? Do they have extramedullary disease or do they have lesions pressing on the spinal cord? Fast-growing disease and treatment-related. If I had someone that was put on lenalidomide maintenance and relapses in 3 months, I'm going to want to switch classes. I may not want to go right to pomalidomide. I may want to switch mechanisms of action. And furthermore, do people have residual toxicities from drugs within the class? So we really kind of put this all together and do the best we can. Now, to give you an idea of how heterogeneous the group is, this is some data, albeit a few years old, that looked at the most common regimens that were given in the second line of therapy. And, we can see here is the evolution from 2010 to 2016, some of the more common regimens that we know, VRD, KD, CyBorD, and these are the most common. And this is all the rest of them. And this is really just put up for shock value. And again, part of this is that I just finished watching Queen's Gambit. I know a little bit too late, but they talk about how in chess that once you get beyond 3 or 4 moves, the number of possibilities becomes greater than the number of atoms in the universe. And I kind of feel that that's the way myeloma is as well, that we have so many options and so many drugs. The question is, how do we put it into some framework that makes sense so that we can kind of more universally apply all of these metrics and come up with the optimal way to treat our patients? So a few things to keep in mind. One of them, and I think Joe pointed this out perfectly, is, despite the fact that we've had about a dozen approvals in the last decade, the patients don't get to 11th, 12th line therapy. The majority of patients only get 3 or 4 lines. So if there are drugs that you believe are good or are good for a particular individual, don't save them for that rainy day, because that rainy day may never come. Now, there's been a variety of approaches to figure out how to sequence therapies. And sequencing trials are difficult because you can't mandate now what regimen is going to be optimal a year from now or 5 years from now. But we try to figure it out. And I really like this flow chart that was published by Chim and colleagues, really kind of separating things out into early relapse, intermediate relapse, more advanced relapse. And, one of the big things is, what drugs are you refractory to? So, yes, we're going to consider patient and disease-related factors, but treatment-related are kind of the first pass. If you're Velcade refractory going into your second line, not going to use a Velcade-based regimen, probably an IMiD-based regimen. If you're Rev refractory going into your second line, we're not going to use Revlimid. And then we move on to the dual refractory to Revlimid and Velcade. Triple class refractory to Revlimid, Velcade, so a PI, a proteasome inhibitor, and a CD38. And then there's quad refractory, 2 IMiDs and 2 PIs, and pentarefractory. So we really quickly start running out of some of our more traditional drugs. Now, our colleagues over at the Mayo Clinic have developed their approach, what they call their MSMART guidelines, about how to approach their early relapse settings. So here, again, this data is quite interesting, but for the most part, this is some of our key opinion leaders. So I think this represents a great place to go as a resource to think about, how do our colleagues at the Mayo approach this? If you're fit and doing well and you're on Revlimid, they recommend things like KPD or Daravel-Dex. If you're off therapy, you want to use more of a Revlimid-based regimen. Later relapses, kind of including more pomalidomide-based regimens or even alkylator-based regimens. And ultimately, when you get to those more advanced places, kind of, gloves are off. You can do whatever you want and consider, things that are a little further out there like VDT PACE. So we also look to the NCCN guidelines. And, although the NCCN guidelines could be extremely helpful for many diseases, I remember the last time I treated colon cancer more than a decade ago. And I went on to NCCN, and after, surgery for stage 2 or 3, it was 12 cycles of modified FOLFOX6. It was pretty clear cut. But when we look at the myeloma guidelines, you'll see here that although they now break them up into preferred and other regimens, it's listed in alphabetical order to not show distinct preference. So you may look at this and say, well, bortezomib-based regimens are better than daratumumab. And no, it's just that B comes before D. So it really is quite difficult to figure out what's the best regimen for each individual patient. So, at least the way that I conceptualize it is the first pass is going to be, what's your core of therapy, or what are you progressing on? So for patients who progress either on Velcade-based maintenance or no maintenance, the people who are not Revlimid refractory, Revlimid or lenalidomide-based therapies are going to be your first relapse regimens. And here's 4 of the leading phase 3 studies inviting KRD, ERD, DARA-RD, and IRD. And if you look across the board, with IRD, ERD, and KRD, we see median progression-free survivals hovering around 2 years, whereas Dara-RD got almost 4. So I think one of the things that I take away from this is that if you are not Rev refractory going into your first relapse, DRD really offers your best option. Now, the majority of people in the U.S. are Rev refractory going into second line. So if you're transplant eligible, people typically get VRD, transplant, Rev maintenance, and progress. The transplant ineligible tend to get VRD, and then they go on to Rev maintenance and progress. Either way, Revlimid refractoriness is very common in the U.S. in second line. And here we look to PI-based regimens, things like Dara-Veldex from the Castor study, KD versus VD from the Endeavor study. Unfortunately, panobinostat is no longer available in the U.S., but from our colleagues up in Boston, the Optimism study of PVD and the Bellini study showing venetoclax-Veldex. Now, although venetoclax seems to be an excellent drug for patients with 11-14, so far, it's still trying to figure out where it belongs in the relapse paradigm. But again, one of the things that we see here is the median progression-free survivals seem to be optimized if you haven't had daratumumab, incorporating daratumumab. But one of the things that was really interesting out of Endeavor is that if you were PI naive or PI sensitive, Kyprolis-based regimens seem to perform better than Velcade-based regimens. So again, you have to figure out based on some of the other risk factors like neuropathy or cardiovascular issues. But in a head-to-head KD versus VD, KD came out not only with a progression-free survival advantage, but an OS survival advantage. And this was most pronounced in patients who were PI naive. So, for example, if you got Dara-Rev-Dex up front and then progressed, KD is actually an excellent potential option. But, we very quickly move beyond the Revlimid and Velcade-based regimens. And, carfilzomib-based regimens are very common in second and third relapse. And here we see a variety of the trials that have led to different options. And one of the areas that I think has made carfilzomib so complex to use is there's so many options of how to use it. And it's the question of, is it dosed once weekly or twice weekly? Is it 2 to 10-minute infusion or 30-minute infusion? And then the dose, is it 20, 36, 45, 56, or 70? And a lot of this depends upon how often and what your combo is. So one of the things is that if you're combining it with Revlimid, you can't go higher than 56 per meter squared because at the dose of 70, we found that the rate of cardiac toxicity was too high. However, if you give carfilzomib with Dex or carfilzomib with Dara or carfilzomib with Cytoxan, you can go to the 70 per meter squared dosing. So I think although carfilzomib is utilized less and less often due to some of our excellent drugs, for patients who have never had bortezomib or have neuropathy from their original bortezomib, carfilzomib can be an excellent option for how to treat patients. Pomalidomide, being a second-generation IMiD, is also one of the cornerstones of early to mid-relapse options. And here we see a variety of different combinations, with some of the better ones being the monoclonal-based regimens of Icaria or Quellius or Apollo, basically Darapom and Isapom. Now, I think that we have a variety of options of how to use pomalidomide, and a lot of this comes from, well, what did you get just beforehand? If you're progressing on Revlimid, I think any of the Elopom, Darapom, or Isapom are great, just like KPD is a great option. However, if you're progressing on Dara and Revlimid, KPD might be a better option so that you're bringing in not only a second-generation drug going from Rev to POM, but the new MOA, either adding on a proteasome inhibitor or a monoclonal antibody. Now, daratumumab has clearly come out as the Rituxan of the myeloma world, and as CHOP became R-CHOP, ICE became RICE, we're adding daratumumab to everything. And here we see every regimen in myeloma plus Dara. And there's some really great data looking at it where Dara is dominating upfront and early relapse, and even some very interesting data coming out of our colleagues at Mayo about the advantage of using it very early on. So I think if you're not quite ready to use Dara in the upfront setting, use it at first relapse. However, there's some really great data now incorporating Dara into our upfront regimens like Dara RVD or Dara RevDex. So it really is probably most efficacious early on in our approach. Now, I mentioned before that the majority of patients in the U.S. progress on lenalidomide, so we're always looking for non-len-based regimens in the early relapse. And here's some of the data for our leading phase 3 trials. And we can see some of the best outcomes really come from IKEMA and Candor, DKD and ISA-KD. Now, obviously, Bellini here is a bit of an outlier because people with translocation 1114 do amazingly well with venetoclax-vel-dex. We're going to focus on the more FDA-approved options at the moment. And we really see that ISA-KD and DARA-KD are phenomenal. So, if you have a more aggressive relapse on Rev maintenance, although many of us put patients on DARA-POM or ISA-POM, both DARA-Kyprolis and ISA-Kyprolis are really showing even better data. So number one, it's a great regimen for the more aggressive, and there's some really nice matched adjusted indirect comparison studies showing that CD38s plus Kyprolis seem to be some of the most efficacious regimens in the first relapse setting. Now, becoming triple-class refractory is becoming a major issue. Now, again, triple-class refractory to a PI, an IMiD, and a monoclonal. And while this used to happen not very commonly, and if it did, it would take many, many regimens, we are now seeing this earlier and earlier on in the myeloma world. And if you consider that, I remember there was a time where patients would get Revdex, then Pomdex, Veldex, then Cardex, and then Daradex, and come to me triple-class refractory after 5 lines. Now with patients getting Dara RVD up front, you could be triple-class refractory in your first or second relapse. So really trying to focus on how to manage these patients is becoming more and more critical. And we know from some real-world data and some studies like Mammoth that once you become triple-class refractory, your outcomes start to become quite dismal, despite the fact there are a number of options available. So we look and see that the overall group here in patients who are CD38 refractory, median overall survival is 8.6 months. But if you were penta-refractory, refractory to Rev, Velcade, POM, Kyprolis, and Dara, your median overall survival was 5.6 months. So for those patients, it's very crucial to seek out the new mechanisms of action to try to offset that. Now, one of the things that we've kind of looked at is, well, how does ELO fare after Dara? And the answer is not that well. One of the things that ELO uses in terms of cell kill is that it activates NK cells. So it attacks the myeloma cells, but also activates NK cells. NK cells are universally CD38 positive. So even though they're potentially more activated after Dara, there's very few NK cells, and this really may hinder ELO, at least in terms of resequencing. So we generally don't give too much ELO after daratumumab or isatuximab. So how do we approach triple-class refractory? We seek out new MOAs. Last year, we had the approval of belantamab mafodotin based off of the DREAM2 study, which was presented by Sagolonio from Emory. And this provided belantamab, which is a BCMA-targeted antibody-drug conjugate. The drug was approved without dexamethasone for your brittle diabetics. It's a really great option. The drug is given intravenously once every 3 weeks. And it has a response rate in heavily refractory patients of about 30%. One of the things to look out for is that the drug was approved with a REMS program because it can cause microcyst on the cornea and keratopathy. So it's crucial that the patients be seen either by an ophthalmologist or optometrist within 1 week prior of starting and within 1 week prior to every dose. There's a number of mitigation strategies out there to help offset this. However, the biggest thing has to do with dose interval. So instead of giving the drug every 3 weeks if you're developing keratopathy, consider giving it every 4 to 6 or even every 8 weeks. Now, as always, once a drug gets approved in the end as a single agent, we try moving it up into other combinations. And the DREAM6 study presented by AJ Nuka looked at combining belantamab with bortezomib and dexamethasone in an earlier line. So here, these are patients with at least one prior line of therapy, and he showed an overall response rate of 78% with a clinical benefit rate of 83%. Now, it turns out that the keratopathy is essentially all reversible. So despite the fact that having grade 1, grade 2 is quite common, if you hold the drug, it does get better. So I think this really helps patients overcome that initial fear of the drug. Now, the Algonquin study that was presented by Suzanne Trudel at this year's ASH sought to combine pomalidomide and dexamethasone with belantamab. And here we see what's kind of across the board in a lot of the DREAM studies, a variety of different dosing strategies to pinpoint what is the optimal approach with this 3-drug combination. So far, we see that the 2.5 milligram Q4 week has been an extremely efficacious dose. Here, the overall response rate was 95%. Again, short follow-up, but very, very impressive. And so far, it looks like giving either the 1.92 or the 2.5 mg per kg Q4 showed deep responses, although 2.5 seems to be a little bit better. And giving this along with pomalidomide and dexamethasone is a great option. Again, the reason where I would think this is going to be optimal is, people getting something like VRD, transplant rev maintenance, and then having DKD or ESA-KD as that first relapse for aggressive disease. Well, how do you follow up a patient who's refractory to daratumumab but still POM naive? And I think a BCMA ADC like Blenrep plus POM-Dex would be optimal in that scenario. Now, selinexor originally had its approval in July of 2019 as a single agent or doublet along with Dex based off of the STORM study. It received two other FDA approvals, one for diffuse large B-cell, but another in myeloma based on the Boston study, the combination of XVD, basically the selinexor version of the DREAMM-6 study. Now, this is an extremely interesting drug. It's a mechanism of cancer resistance that is present across multiple tumor types. We see here that the overall response rate in heavily refractory patients is around 30%, and you'll see the use of clinical benefit rate here of around 44%. Remember that clinical benefit rate is MR or better, 25% reduction in myeloma or more, whereas overall response is 50% or better. And you may say, well, this is silly. And the example I would give is if you've had someone who's had 7 lines of prior therapy and they start treatment with an M spike of 1 and you get them down to 0.6, they would not count as an overall responder. They would count under clinical benefit rate because it's more than 25 but less than 50%. How does this translate? Here we see overall survival by response. And clearly the people who get PR or better, the overall responders, had a median overall survival of 15.6 months. And the people who progressed right off the bat did horribly. But the people who got MR or better, that 25% reduction or more, had the same overall survival of 15.6 months. So MRD is absolutely great, and getting patients there is great. But I couldn't agree more with Joe that getting there is not the end-all, be-all, and patients can still do quite well even if they don't have that incredibly deep response. So even getting an MR in these advanced patients is some modicum of success. Now, the Boston study, which led to the second approval of selinexor in December of 2020, compared XVD versus VD in patients with 1 to 3 prior lines. Note here that what the big change between the STORM study and Boston and STOMP was that in STORM, because selinexor was the main drug, we had to give the drug twice weekly at 80 milligrams, which is a fairly toxic way of giving the drug. As you move it earlier on and combine it with other drugs that get that synergy, we reduced the dose from 80 twice weekly to somewhere between 60 and 100 milligrams once a week. And the MTD for Boston was 100 milligrams once a week. Subsequent studies have shown very little difference in efficacy between the 60 and 100 milligram doses. So if you have someone who's a little bit older and frailer, giving them 60 or 80 once a week in combination can be quite efficacious. Here we see the primary endpoint of PFS, and we saw improvement in XVD over VD of around 9.5 to 14 months. So for patients who progress early on or refractory to multiple MOAs where you want to bring in a new mechanism of action, like the triple class refractory, either Blenrep or selinexor have great data in these patient populations. And again, we see here overall response rates improve from around 62 to 76%. Now we see this across the board. I think a lot of people following the STORM study were gun shy about the use of selinexor in older patients. But we see here for all the subgroup analyses, and this was presented by Thanos Demopoulos, in older 65, high risk, renal insufficiency, we see pound for pound, XVD does better than VD. So I think with proper dosing and proper supportive care, we can get patients to tolerate the drug quite well. Now, the STOMP study was a basket trial combining selinexor with essentially all of our backbone studies for myeloma. And here again, the dosage of selinexor was between 60 and 100 milligrams once a week, a far better way of tolerating the drug. So here we see the results of the XDD regimen, selinexor, daratumumab, and dexamethasone. And note this was done a little while ago where daratumumab was still intravenous. However, we substitute sub-Q quite readily. And again, people will say, well, where does XDD fit in? And I think this has to do with myeloma is all about going against Billy Idol. And when I say, what does it mean to go against Billy Idol? Well, Billy Idol likes to say he's dancing with himself. And myeloma drugs like to dance with their partners. So if you have someone who gets VRD and then Rev maintenance after transplant and gets KPD as a second line, well, now you want to use daratumumab, but you're refractory to Kyprolis, you're refractory to POM, you're refractory to Rev. I think that type of patient is where XDD is going to be critical to not only bring in daratumumab, but selinexor. And we see here from the waterfall plot, amazing response rates across the board. Now, what if you instead got VRD transplant Rev maintenance and you got Dara-Cardex or Isa-Cardex? Now you want to use pomalidomide. What was pomalidomide going to dance with? Selinexor or Xpovio. And a few things to note here. Not only was the overall response rate around 50%, the clinical benefit rate of almost 70%, but even in the POM refractory group, the overall response rate was 35% with a clinical benefit rate of 64. So if it was a case where you have someone on Pomdex and they're a little bit older, they just want to be on Pomdex, and the COVID rates flare up and you want to keep them on an all-oral regimen, you can add selinexor. Again, here it's 60 milligrams once a week. The other benefit of this regimen is that all three drugs penetrate the CNS. So for patients with leptomeningeal disease, this is our go-to regimen because all three drugs will penetrate. We've had a lot of surprisingly amazing durable responses in patients with leptomeningeal myeloma. XPD, again, great responses across the board, even for people who were POM refractory. Now, XKD, this is for the people who get Dara-Pomdex in early relapse. Now, selinexor needs a dance partner, and this is where I use a lot of XKD here with the selinexor dosed at 80 milligrams once a week. And a lot of this this work has been done by a lot of people, including, I believe Dr. Stadmauer has done a bit of this as well. We see overall response rate of 75% with a clinical benefit rate getting up to almost 80%. So really trying to find the optimal dance partners for two drugs and a steroid. And I know we went through quite a bit, but the kind of conclusion is myeloma is extremely heterogeneous, both from a disease standpoint and a treatment standpoint. Quads are really emerging with some great data up front with drug regimens like the Master regimen, Griffin, Perseus, Cassiopeia. But, in the relapse, we're still kind of in triplets. And it's really all about sequential triplets. And when you're treating someone sequential triplets, think about it like chess. This is my move now. How does it affect the next move and the move after that? So if you're going to bring in a new drug, like a second generation, you're going to go from Rev to POM or Velcade to Kyprolis. Make sure that not only do you bring in a next generation, but you bring in a new MOA. If you're CD38 naive, bring in CD38. If you're BCMA naive, bring in BCMA. If you're XPO naive, bring in an XPO inhibitor. So really think about the MOAs and introducing new MOAs so that the disease that's remaining, which is already resistant to many of the mechanisms you've already used, you catch them off guard and get deeper responses. Remember that patients only have around 3 or 4 lines of therapy total, so really try to plan that out as much as possible. And for patients who are blowing through regimens quite quickly, referral for clinical trial is key. And I will say thank you, and I think we have our post-test clinical vignette. All right, so back to our 64-year-old male with a history of IgA lambda myeloma, dairy salmon 2A, fish show, and 1114, gets RVD, transplant, has grade 1 neuropathy from treatment with bortezomib. He opts for no maintenance, and 3 years later develops a biochemical relapse. Which regimen offers the best data for this patient? And here we have VRD, IRD, DRD, XVD, or belantamab mafodotin. And we'll keep this on for a moment. And I'm humming the Jeopardy theme song in my head. I hope you are as well. Trying to think of anything else fancy to say right now to kill the dead air. Coming up next is going to be Dr. Ed Stadmauer, an absolute amazing human being and clinician. Really have nothing bad to say about Ed. I mean, something bad to say about almost everyone, but really nothing bad to say about Ed whatsoever. And I know Nina Shaw is coming on later. And the big question is whether or not Nina will be on a Peloton while giving her lecture. It's the most impressive thing to watch someone literally blow everyone away. Oh, Josh, shut up already. Okay. Do we have the numbers here? Oh, and here are the numbers. All right. So we have IRD, DRD, and XVD. And I think all of these are great options. I worry about XVD in someone who got neuropathy from only induction bortezomib. IRD is a great option, but DRD really does have the best data. So if you look at IRD from the tourmaline study, the median progression-free survival is around 24 months, 20 to 24 months, depending upon a few factors. Dara-Revdex got up to around 44.6 months. So DRD was what I was going for there. And with that, I will pass it over to Professor, Director, Chair, Dr. Ed Stadtmauer.
Oh, Josh, thank you so much. You are the best, and Joe's the best, and Nina's amazing, and it's really, I really appreciate the opportunity to talk to all of you tonight. Let's start off with our pretest. So let's see. So RS is a 62-year-old woman who presented with anemia and renal failure, and the SPEP showed a 3.4 gram per deciliter M spike, and bone marrow biopsy showed 35% clonal plasma cells. Skeletal survey was negative, treated with RVD with a complete response, an auto transplant, and lenalidomide maintenance therapy, but within 12 months of her auto transplant, she relapsed. She got the Dara-Pom-Dex regimen, never achieved a complete response, progressed after 9 months, subsequently progressed on the Dara-Car-Dex regimen. How would you treat her at this point? And so the options that are on this vignette are a second auto transplant, as she had a prior one, anti-BCMA CAR T-cell therapy, allogeneic stem cell transplant, or ixazomab monotherapy. So we'll give you a little time to answer this, and I also think of the Jeopardy theme during this this process. It is. I think that some of these questions really are the most useful to the organizer for seeing how effective our presentations are. All right, I think we will move on. So what I'm going to talk to you about is BCMA as a therapeutic target and the advantages of CAR modified T-cell therapy for patients with relapsed and refractory myeloma. Here are my disclosures. And as you heard from Josh, triple class exposed relapsed myeloma has a poor outcome. And I also agree. I think this Monmouth study was really an important study to make this clear. All of these patients had progressed on CD38 monoclonal antibodies, and there was a median of 5 prior therapies, and about 54% of the patients were triple or quad refractory, and about a quarter pentarefractory. And most importantly, when you treated them with a next line of therapy, regardless of what that was, less than a third of the patients responded to this therapy. There was an 11%, only an 11% VGPR or greater, and progression-free survival was very short, less than a little over 3 months, and overall survival was a little over 9 months. And so what are the options for relapsed triple-class refractory myeloma? And you've heard many of them. The one I wanted to add was more and more we go back to sort of basics and give infusional chemotherapy in this setting. The DPACE or the DACE or other alkylating agents, doing a salvage stem cell transplant. You heard about selinexor. You've heard about venetoclax for patients, particularly those with the 11-14 translocation. And you've heard about BCMA-directed immunoconjugate, the first FDA-approved BCMA-directed therapy. And then, of course, the investigational agents that we're going to talk about now, the BCMA-directed T-cell engagers, such as CAR T-cells or bispecific antibodies that Nina will talk about after this. And, of course, the whole area of non-BCMA-directed T-cell engagers, CD38 CAR T-cells, CD38 immunoconjugates, and other bispecific antibodies. But what we're going to focus on during this talk are the BCMA-directed CAR T-cells. BCMA is the B-cell maturation antigen, and it's nearly universally expressed on myeloma cells and largely restricted just to plasma cells and maybe some mature B cells. Expression of BCMA has two agonist ligands, the APRIL and BAFF. And in myeloma, the serum levels of APRIL and BAFF are very elevated. And the more advanced stage of myeloma, the higher concentration of these ligands. And upon binding of these ligands to BCMA, multiple growth and survival signaling cascades are activated, stimulating the myeloma cell. So it makes sense that if you could block BCMA, you may induce apoptosis and stop this process. And in many ways, the BCMA-directed CAR T cells were the first demonstrations or proof of principle of this. This is the three earliest studies from the NCI, from Penn, from Bluebird, where patients with relapsed and refractory disease, on average of 7 prior lines of therapy, had very high response rates. Anywhere from 2/3 to almost 100% of the patients responded to BCMA-directed CAR T cells, with 1/3 to almost 80-90% having a greater than VGPR. And it was relatively well tolerated, though this cytokine release syndrome, which we'll talk more about, was very common. High grade and serious CRS was actually relatively uncommon. And though neurotoxicity was uncommon, and severe neurotoxicity was very uncommon. So this led to an explosion of BCMA-directed targeted therapies, the antibody-drug conjugate that you heard of, and Nina will probably speak more about, the BCMA-directed CAR T cells, and then BCMA-directed T-cell engagers. And the focus, of course, that I'm going to have is the CAR T cells, and the key to this is the infection of these cells with lentiviral vectors to put in them genetic material for them to create a chimeric antigen receptor that has an antigen binding site externally, and then going through the cell, and then within the cell, these signaling domains, these co-stimulatory domains that lead when the chimeric antigen receptor latches onto a cell that has BCMA to activation and toxic cytokines being produced to destroy the tumor cell. This is a list of many, though not all, of the BCMA-directed CAR T-cell trials for patients with relapsed and refractory myeloma. And what you can see is that they're actually very similar in terms of the patient characteristics. Age was average of 61. The cytogenetics being high risk was perhaps a quarter to a third of the patients on these trials. The median number of prior lines of therapy was 5 or 6 lines of therapy. The majority of the patients were triple refractory, maybe anywhere from 2/3 to 90%. And many of these studies allowed bridging therapy. The ide-cel, the KARMA study, the one agent that is now FDA approved, is a humanized BCMA that used the 4-1BB and the CD3 zeta as co-stimulatory molecules. The BB21217 utilizes the same BB2121 as in the ide-cel, but it's cultured with PI3K kinase inhibitor to enrich the T cells with memory-like phenotype. The Orva-cel, that product tried to maximize the ratio of CD4 and CD8 in rich cells to encourage memory T cells and see if that worked better. And then the Cilta-cel, the Cartitude group of studies, used the double antigen attaching characteristic of that agent. And you can see that the results, I'm more of a lumper, but I would say the results are very similar. The overall response rates in all of these studies is about 70 to 100%. The CR rate is somewhere in the neighborhood of 1/3 up to 80%. MRD negativity is very high and up to 80 or 90%. And patients can have a significant months, if not years, of progression-free survival. But unfortunately, with these initial products, it still is unclear that patients are cured with this approach. The KARMA study, the ide-cel study, is a good example of what most of these studies look like, which is you take patients who have 3 or more prior lines of therapy. They've been previously exposed to IMiDs, proteasome inhibitors, and CD38, and refractory to the last prior therapy. The patients undergo a steady-state leukapheresis and bridging therapy while the ide-cel is being manufactured. And in the initial study, the vast majority of manufacturing was successful. The patients then received what has become the standard fludarabine cytoxan preparative regimen or lymphodepleting regimen of 30 milligrams and 300 milligrams daily for 3 days, and then a single infusion of CAR T cells. In the initial study, there was a phase 1 increase in the dose of the cells that were administered, and for the highest dose, the dose that is utilized, 82% of the patients with this relapsed refractory group of patients responded, about 40% going into a complete remission. And the patients who were in complete remission had a median of maybe 20 months duration of progression-free survival. But as you can see, patients who had less deep response had shorter durations, and none of these curves have a look like they have a plateau suggesting cure. MRD negativity was about 50%, and at about 1 year, about 78% of these patients were still alive. And so this is what led to the FDA approval of this first BCMA-directed CAR T cell. This data has been updated at the most recent ASCO meeting, and you can see that currently the overall response rate in this group of patients was 73%, about 1/3 complete remission. And almost regardless of the degree of number of prior therapies, the patients had a similar overall survival, though the patients who were in complete remission did better than the patients who were less than complete remission, and the patients who were the RISS stage 3 had a more difficult or a shorter outcome. there are some predictors of who the patients are going to be who get a complete remission to the ide-cel. And it looks like circulating soluble BCMA predicts a lower chance of going into complete remission. So the lower the amount of circulating BCMA, the better. And then having the presence of a lot of inflammatory cytokines, as evidenced by an increased ferritin or increased D-dimer, actually increase the likelihood of having a good response. The next generation ide-cel was this BB21217, which, as I said, is the same ide-cel but was cultured with a PI3 kinase inhibitor to enrich the T cells for a memory-like phenotype. And the philosophy was this phenotype may persist and function longer than non-enriched CAR T cells. And in the end, the results were similarly impressive as ide-cel. 73% of the patients had responses, and about a third of the patients had deep, complete remissions. But whether this really is any better than the ide-cel is up for debate. The Orva-cel, the study that utilizes a balanced CD4 and CD8 maximization of the product, also had remarkably high responses, 80–90% of responses with a very high VGPR or greater incidence, and a very high MRD negativity, but once again, similar, I would say, to the outcomes of these other groups. I want to spend a little bit more time on the cilta-cel studies, the CARTITUDE studies. This agent has the two binding domains for BCMA, but also has the 4-1BB and the CD3 zeta co-stimulatory aspects to it. And the CARTITUDE-1 study was a very similar study to the KARMA study, with 3 or greater prior lines of therapy, prior PI, prior IMiD, anti-CD38 therapy, apheresis, allowed for bridging therapy, the flu-cy lymphodepleting therapy, and a single infusion of cilta-cel. And you can see in the most recent update from ASH, from this recent ASH, that a remarkable 98% of the patients responded, and about 95% of these patients had a greater than VGPR. And the progression-free survival and overall survival medians have not yet been met with approximately 2 years worth of follow-up. There's a number of other cohorts that have been investigated in the CARTITUDE series of studies. One of them looked, and they look at earlier groups of patients. And one of them, the cohort A, looks at patients who had just 1 to 3 prior lines of therapy, and the infusion of these cells after flu-cy lymphodepleting therapy showed a very high response rate, 95%, and a CR rate of 85%, with a high level of CRS, but low level of high-grade CRS, a low level of neurotoxicity. And patients who are nearing a year and a half to 2 years worth of progression-free survival. And cohort B took patients who had short initial progression-free survival, less than 12 months till their relapse, and showed a similar 95% response rate and about 80% entering complete remission. Again, low CRS and low neurotoxicity. Some looking at subgroup analysis, the group of patients who had a higher burden of myeloma, patients who had greater than 60% plasma cells in their bone marrow, patients who had plasmacytomas, that group of patients had a lower likelihood, about 50% chance likelihood of being alive at 2 years and are probably some negative prognostic sign. Now, there's an interesting neurotoxicity that has been observed in the cilta-cel group of patients, movement and neurocognitive disorders, sort of like a Parkinsonian-like neurotoxicity, which occurred in about 5% of patients in the earliest trial, some of these neurotoxicities were fatal. And what they found was that it did seem to correlate with a higher tumor burden, a higher CRS, a higher incidence, a likelihood in patients who had neurotoxicity, a higher incidence in patients who had a high CAR T-cell expansion. And so they implemented some strategies to try to minimize this by utilizing more effective bridging therapy prior to the infusion of the CAR T-cells, early and aggressive treatment of CRS and ICANS. And in the end, the next 200 patients who were treated had a much decreased movement and neurocognitive disorder incidence of about 0.5%. But this remains an area of interest. So based on all of this, who should be referred for CAR T cells for myeloma? With the current data that we have, it's for patients who have relapsed and refractory multiple myeloma after 4 prior lines of systemic therapy. There seems to be no upper age limit. There's no evidence that the tumor must demonstrate BCMA by some test. And then there's a variability of practice in terms of the performance status of the patients, cardiac, renal, and pulmonary reserve, whether patients who have renal insufficiency should be doing this, and the concern about autoimmune disease or neurologic conditions. But these are considerations that have to be taken seriously. As you can see, we have very amazing responses with these with the BCMA-directed CAR T cells, but it's still not curing everybody, and it still is, and there still are many relapses. So how are we going to optimize the CAR T cell products? And there are many ideas out there, including gene editing with PD-1 knockout, allogeneic CAR T cells. There's, of course, ways, as we talked about, to try to maximize the manufacturing. But I think probably one of the more interesting ones is with the gamma secretase inhibitors, which might increase the expression of BCMA and therefore allow for higher response rates. And then, of course, there's the big question of patient selection. Should we, oh, geez. Can you hear me still? My picture went out, but the okay. The I'm gonna have to get a whole new set of computers here. But anyway, the most interesting question is earlier lines of therapy. Shall we take patients and see if we can take T cells that are less exhausted and take patients who are less heavily treated and really see for better results. There are many ongoing trials of ide-cel and cilta-cel, and then there's many ongoing trials of other types of agents. To me, the most interesting thing is a more rapid manufacturing. If we can actually create these cells within 2 days so that a patient could be harvested, do the manufacturing, and infuse the cell within 5 days, that would be pretty remarkable in terms of increasing the utilization and decreasing the likelihood of toxicity for these patients. Speaking about toxicity, I want to spend just a couple of minutes on the primary toxicities that are unique to these agents, cytokine release and neurotoxicity, You know that cytokine release is driven by interleukin-6 and inflammation of these cells. And you know that the grading system has actually been simplified so that a fever is grade 1, a fever with mild hypotension, mild hypoxia, grade 2, a fever with more significant hypotension or hypoxia is grade 3, and then, of course, multiple vasopressors and intubation would be a grade 4 toxicity. And we can now treat the CRS very well with tocilizumab, the IL-6 inhibitor. And this is usually given relatively early with or without steroids, certainly once it's grade 2, both toci and dexamethasone. And then as the grades go up, higher and higher doses of steroids. In terms of neurotoxicity, it does look like disease burden increases the likelihood of neurotoxicity, and as well as peak inflammatory cytokines. And pathologically, we've seen that these cells can pass the blood-brain barrier into the CSF, and high cytokine levels can be associated with it. And this is a much more difficult circumstance, certainly, fortunately, a much less frequent circumstance than the CRS. And again, the grading system has been simplified to mild confusion being grade 1, awakens spontaneously, moderate confusion, grade 2, awakens to voice, grade 3 starts being severe confusion and requiring tactile stimulus and any seizure, and grade 4 is, of course, life-threatening, comatose, unarousable, and usually we don't need to treat grade 1, but once it gets to be grade 2 or more, steroids, and more frequently we're utilizing agents like cyclophosphamide to help turn it around. The different agents have very similar CRS and neurotoxicity incidents. About 70 to 90% of patients will experience some CRS, but fortunately high-grade CRS is very uncommon, usually less than 5%. And the neurotoxicity, fortunately, much less common, but and very uncommon to have high-grade, perhaps 3 to 4%. What we are finding more and more is the toxicity of cytopenias. And I think that most of the cytopenias are probably related to the preparative regimen or the lymphodepleting regimen, the fludarabine and the Cytoxan. And that's why I think trying to figure out better and better ways of doing that aspect of it will be very important. And we're also noticing that infections, particularly like viral eruptions like CMV, can occur. It's very important and essential to have a multidisciplinary care team to deliver this from administration, nurses, a great manufacturing group, an infusion group, an apheresis group, and it really takes a village to do this type of work. So you're going to hear a lot in the next talk about the bispecific antibodies, but the advantages of CAR T cells is that it's a one and done sort of treatment. The toxicities are front loaded, and so within a month, most people will have resolved those, and we can see some very durable remissions. But there are manufacturing headaches. Slot allocation has been a major problem. The need for an apheresis procedure, the potential for manufacturing failures, and the potential for disease progression while you're waiting for the cells, the need for lymphodepleting and the cytopenias, and of course, the potential for the CRS and the ICANS. And so far, it's not clear that this is a curative therapy for this group of patients. So Anti-BCMA CAR T-cell therapy leads to high CR and MRD negativity, but durability of responses remain an issue, and the toxicity can vary with respect to the product, the target, the patient, the disease, but being treated earlier and more liberal management has led to improved outcomes over time. So thank you very much. I really appreciate you dealing with all my technical difficulties, and it's my pleasure to introduce Nina Shah, who will follow with a nice discussion of bispecifics and immunoconjugates.
Great. Should I advance to my slide? Oh, I think we have post-test questions, Ed.
Oh, okay. So how would you treat her at this point? So this is the woman who had relapsed and refractory disease after an auto transplant, after maintenance therapy, relapsed within 12 months, and then had Darapom-Dex and Daracar-Dex. So how would you treat it? I probably drank a little bit too much of the scotch before I started. And I probably spilled it on my computer, which probably really made the problem. All right, let's see what you guys have suggested. Well, I guess you got the message, whether or not it was difficult to see or hear me. So thank you very much.
All right. So excited to follow Ed. Very difficult to follow Ed, of course, one of the giants in myeloma and cell therapy, but I'll try to do my best. We have a pre-test clinical vignette, and we'll start here. So this is an 81-year-old man diagnosed with myeloma in 2016 when he had anemia. His creatinine was 1.49. Actually, at the time he was diagnosed, he had a creatinine of 1.49 and kind of had abnormal creatinine sort of throughout. He had IgG kappa, multiple myeloma, amplification possibly of 1Q, 1 to 4 copies, translocation 414, PET was negative, and he has a history of hypertension, cataracts, and bradycardia. So he was started on RVD, and apparently he was only given lenalidomide 5, but he didn't even tolerate the lenalidomide. So anyway, he went on to Cyborg for 4 cycles, got a VGPR, actually went on to maintenance bortezomib dexamethasone for 12 cycles, but then progressed, and then was given single-agent daratumumab for 7 cycles. And I think this is very common. We do a lot of combination chemotherapy, but really in the real world, there are a lot of people giving singles and doublets. Then he progressed and then got carfilzomib, progressed, eventually got elotuzumab and bortezomib and had progression. Now, when he was being seen, his creatinine was 1.38 and his clearance was 44. So I want to talk about the next best immunotherapy option. And I just want to point out the creatinine clearance, 1.3 doesn't seem so bad, but he's 81. So just keep that in mind because that does factor into the Cockcroft-Gault. So what is the next best immunotherapy option? A, isatuximab, B, belantamab mafodotin, C, BCMA bispecific T-cell engager, or D, BCMA-directed CAR T therapy. I know people were asking for Jeopardy music, but we usually have like all the old school rock music, like the 80s music. I don't know where it went. Oh, okay. Sorry, my fault. Just kidding. Now you guys can vote. Thanks, Josh.
You got it.
Okay, great. So really excited to talk to you about therapeutic potential. I don't know where that went. Okay. Therapeutic potential of bispecific T-cell engager and monoclonal antibodies and antibody-drug conjugates in the treatment of patients with relapsed refractory myeloma. As you already know, I'm Nina Shah. I'm at UCSF in San Francisco, California, where it's still daylight here, and ski week. So we're very excited about that. Okay. So here are my COIs. I'm equally conflicted with everybody. Okay. So bispecific T-cell engagers, I would say you heard this great talk by Ed. And now we have the bispecific T-cell engagers, which are essentially the new kids on the block. By the way, I've seen them twice in their new form, as like the new adults on the block. They're very good. Highly recommend them. But this is what we would consider the BiTEs, although that's a trademark name. My daughter made this graphic of the plasma cell and the little chunk of it taken out. Now, what are the bispecific T-cell engagers? They are antibodies that are bispecific. So they are at one end specific for a tumor antigen, for example, BCMA on a tumor cell, as you can see on the right, and on the other hand, specific for CD3, so that they sort of bring together the T cells with the tumor cells, as I always call them, the E-harmony of immunotherapy for multiple myeloma. And what they have really been focusing on is generally, although we'll hear more about this, by B-cell maturation antigen. Now, you already heard from Ed about B-cell maturation antigen, and I just want to point out one thing, which is that I think the most important thing is the bottom of the slide, which is that it's exclusively expressed on the surface of plasmablasts and differentiated plasma cells. And this is important because if you're going to have very effective T-cell therapy, whether it's CAR-T or bispecific T-cell engager therapy, you have to make sure that you're not going to have a lot of off-target effects. And this is very critical, especially for our patients who are already having a lot of comorbidities. So really important that this target is very specific for plasma cells. I want to focus on a couple of T-cell engager trials that really have been coming hot off the press this past year. This is the updated results from the Majestic study. This is a phase 1/2 study of teclistamab, which is a BCMA and CD3 bispecific engager. And you can see here the structure of it, which really does bind both the myeloma cell and the T cell. Now, this was a phase 1/2, well, phase 1 portion of the phase 1/2 study, but we had already seen the phase 1 data, and it had identified the RP2D for teclistamab monotherapy as a 1.5 mg per kg sub-Q weekly dose. And so this data that was presented at ASH was really an update of a lot of the patients that they had on this study. So to cut to the chase, you have overall response rate here of 62%. This is a single agent, so I just want to point that out, 62% overall response rate with a lot of patients getting to VGPR better. 58%. I think that's important because, there's always schmutz in the SPEP, so sometimes hard to say a person's in CR. So I like to look at that VGPR or better statistic. Now, remember, this is sub-Q weekly. These patients were very sick, median prior lines of 5. The CRS was 72%, generally grade 1 and 2, and neurotoxicity was pretty low, 13%. And that's kind of the theme that we've seen with a lot of these bispecifics, that the CRS is somewhere in that range and the neurotoxicity is manageable and lower than it seems in CAR T-cell therapy. Really good median time to first response within 1 to 2 months. They didn't have the median follow-up enough to tell us what the PFS is going to be, but it looks like it's going to beat this 8 months, which is good because they still had patients in remission, over half of them at that follow-up. On the heels of that, we have several BCMA T-cell engaging agents, and I wanted to bring a few of them up, although I won't be able to do all of them in the time that we have. This is the TNB-383B study. This is a BCMA CD3 bispecific antibody, again, for patients with relapsed refractory multiple myeloma. Similarly, this was originally by a company called Teneo Bio, but has now been purchased by AbbVie. So they're running the rest of this trial. But you can see that it's a very interesting molecule because it's actually specifically designed to evade systemic T-cell activation and minimize CRS. And it actually allows this to have a dose that's actually a little bit longer lived. So it's an every 3-week dosing schedule, which I think is actually very convenient if you think about what it is that patients have to go through in marathon therapy. So this is the data from their phase 1 and dose expansion. Now, for all their patients, when they look at all their patients at least the 40 milligram dose, you can see that their overall response rate was 81% with the VGPR or better rate of 69%. Now, if you look at just the 40 milligrams in both the expansion and the escalation, the overall response rate was 60%. And I just want to point this out again, when you look at this type of early data, sometimes the escalation data at the top doses is better than the expansion data. And I think it's really important to look at this because remember, the patients that go on to dose escalation they're like going to this double Dutch. Like they may make it in there, may not. So you have to really make sure you get patients who can wait those slot times. Versus in the dose expansion, there's a little bit more rapid enrollment. So sometimes these overall response rates can vary between the expansion, between the escalation and expansion at the higher doses. But I think what's really important about this agent, as I mentioned, is it's intravenous, but it's every 3 weeks. Again, patients very heavily pretreated, median prior lines of 5. CRS, depending on which cohort you look at, somewhere between 54 to 69%, pretty low grade 1 or 2. And as you can see here, the median duration of follow-ups, not too much yet. So we really don't know how that patients are going to do for longer, but we really hope that this will be something that we can take to the clinic hopefully soon, similarly to teclistamab. And you can see here their duration of response really hasn't been reached yet. So looking forward to a little more longer term data with this. Now, I just put those two up just to show you how these are they're very similar in concept, but there are always subtle differences between these bispecific T-cell therapies. So teclistamab, as you can see here, the median prior lines, if you just go down, there's teclistamab, there's tenayobide, we just talked about, Regeneron, the Amgen molecule, and then the elranatamab, which also had a very nice presentation this past year at ASH. And the patients are very heavily pretreated, just focusing on the BCMA-targeted T-cell engagers here, 5 to 6 lines of prior therapy. Now, the dosing, I think that's something that is different between these, and maybe one of the things that differentiates them. You can see some are sub-Q weekly, some are every 3 weeks, some are every 2 weeks after the 16th, some are weekly, and then you can actually change it 2 weeks later for some of them. The overall response rate, remember, this is a single agent therapy, something that we really don't do very much in myeloma. You're talking about 60 to 80% overall response rate, which I think is very impressive. I always say 60 is the new 30, and this is the reason. We have drugs approved for response rates of 30%, and here we're getting 60 to 80%. CRS, very manageable, generally can be managed with some pre-meds, especially in the elranatamab, and some priming doses with teclistamab. You can see here somewhere between 54 to 87%, again, generally low grade. Neurotox, I think, as I said before, is generally lower than what you see in CAR T-cell therapy. So you can see here some of these had very little neurotox. And of course, these are treatable, again, CRS with tocilizumab, neurotox with steroids. And then the separate things about each of these. Some of them are sub-Q, some of them are Q-week, some of them are IV. And then what I thought was very interesting was that the elranatamab, which is the lower one there on the boldface, that some of them had prior BCMA therapy. And so 22% of their cohort had actually been treated with a prior BCMA targeting agent, not elranatamab, but another one. And 70% of those patients responded, which I think is a little bit of sneak peek into data of how we are thinking about maybe we may be able to sequence some of these BCMA therapies. So if we're doing so great with BCMA, can we do something better with something else? So this is the updated results from the Monumental study, which is a first-in-human study of talquetamab, which is a bispecific engager to both GPRC5D and CD3. So instead of BCMA, this is targeting GPRC5D, which is another antigen that appears to be very specific for plasma cells as well as hair follicles and skin, which does sort of explain some of the data that we'll see in the toxicities, but a very similar idea to what we've just seen with teclistamab. Now, this had actually been in phase 1, and the RP2D was identified as a weekly sub-Q dosing of 405 micrograms per kilogram, but they also wanted to present data from this updated first RP2D, but also a second RP2D, which was identified at 800 micrograms per kilogram every 2 weeks. So I think they also understand that patients who respond to this respond for a long time, and they want to make sure that they give a user-friendly sort of paradigm to follow. So here you can see that whether you're looking at the 405 or the 800, the response rates of single agent talquetamab are very impressive, 70% and 66% respectively, with very nice deep VGPR or better responses over the 50%. We don't have much long-term follow-up on these patients, but I think it's important to remember that we are seeing hopefully some duration of response. And I think in the next ASH and ASCOs, we'll get some more information. Now, what about something else besides GPRC5D? Well, there's cevostamab, which is another bispecific T-cell engager, again, single agent trial, which was presented last year, but has been updated a couple of times for this phase 1 study. Now, this targets FcRH5, which is a protein that's expressed exclusively in B-cell lineage cells and seems to be more in myeloma cells than normal B cells. B cells, and similar to BCMA, nearly ubiquitous expression on myeloma cells. So that's a really good thing that we want to be able to see because we want to be able to target this appropriately. Now, they had some phase 1 dose finding experience. And they updated this data this past year at ASH. So what happened here? So first of all, this is an IV Q3 week dosing. Median prior lines here are 6. They did have 81% CRS and neurotoxicity of 14%. But I think really impressively, if you look at these higher dose levels, you can see 56.7% of patients responded, a third of them VGPR better. Again, this is a phase 1 single agent study. So you really have to think about how well these drugs are doing relative to the historical experience that we have in these patients with relapsed refractory myeloma. Seems like the responses occur early, and they did have some MRD negative data, but I'd like to see what the longer term follow-up is going to be. Here you see that in the single step-up cohorts, the 14.1 months seems to be that they had a median duration follow-up of 14.3 months. A lot of patients are still looking good with the median duration of response 11.5 months. So I think this is pretty impressive data considering this is just a single agent therapy. Some of these patients actually did have prior BCMA exposure, and we'll talk about that in a second. And we think about how are we going to sequence all these things in the new era? Are we going to do BCMA, GPRC5D, FCRH5? I don't know that we have enough to tell us what matters, because what we do know is myeloma is incurable. So what we need are options no matter when we're going to be able to sequence them. So if you look here, just focusing on the bottom here, these are the non-BCMA targeted bispecifics. And you can see talquetamab, where the patients were very heavily pretreated in either of the RP2D cohorts, response rates around 70% with a pretty respectable CRS, but easily handled, very low neurotox. Now, 27 and 16% of patients in the talquetamab study had prior BCMA treatment. And that was a good thing that we were able to see some data on that. We don't have all the data about their response, but there is this sort of change in taste, skin, nail AEs for 75% of patients, generally well managed by topical treatment. What we know about the 405 dose is that at least half the patients were still responding at 10 months. So very exciting to see what's going to happen with talquetamab. There's a lot of combinations planned, et cetera. Cevostamab, also very heavily treated patients, Q3 week dosing. They seem to have a 57% overall response rate in the higher doses. The median duration looks like 11.5 months. And there were about a third of patients that had prior BCMA treatment. And there was a little bit of discussion about that at ASH, but the data was not included in the slides. So, well, that's great. If this is so great, can we do better? I mean, if you're getting an ice cream cone, can you get an ice cream sundae, right? And that is one of the things that I really liked about this particular abstract, which is a phase 1b study of subcutaneous talquetamab plus daratumumab in patients with relapsed refractory myeloma. Now, of course, we're myeloma docs, so we love to combine all active drugs possible, but there is some rationale for doing this because there is some T-cell expansion after daratumumab. And if you could capitalize on that with talquetamab, there is the potential to have synergy between these two patients. Now, between these two agents. Now, I will point out that a lot of these patients are very heavily pre-treated, right? They had a diagnosis of at least 3 prior lines of therapy, and they might have been double refractory to PI and imited, and they did have prior anti-CD38 antibody before. So these are patients that we don't always retreat with Dara, but are willing to do in the setting of a clinical trial. And they did look at both the 400 and the 800 dose. So here, median prior lines of 6, CRS 55%, skin and nail events 65%, as we would probably expect. And you can see here the overall response rate across the dose levels, somewhere between 77 to 85%, so around 80%, no matter what the dosing was, especially if you look at that talquetamab 800 sub-Q Q2 weeks, which I think is a little bit more user-friendly. They have 77.8% response rate, which I think is really, really interesting. And even more, what I thought was, what really made this one of the top abstracts for me is this talquetamab and daratumumab led to peripheral T-cell activation and an induction of CD38 positive, CD8 positive T cells. Now, you would think that those T cells would be killed by daratumumab, and I was surprised to see that they had T cell activating data, at least in some of their correlative data, and that they had some interferon gamma data up to support this. I think what this means is that we don't have to be scared to use those two together, and I think it paves the way, really, for combination therapy in this particular setting. So I want to move on now to the antibody drug conjugates, or really conjugate, which is belantamab mafodotin, which is the only approved BCMA-directed antibody drug conjugate for multiple myeloma. This is a humanized afucosylated IgG1 BCMA targeted antibody that also is linked to MMAF, which is the toxin that is conjugated to this antibody. And this allows for binding specifically at plasma cells, internalization, and subsequent release of this MMAF cytotoxic agent within the cell. So this was the first BCMA-directed therapy that was approved, and it's approved for patients with relapsed refractory myeloma after 4 previous therapies. I want to be very clear about the word therapies because it is not the same as lines, meaning that you could count 1 line with both of these drugs, for example, a PI and an IMiD, and that would have counted for 2 of the therapies. So have to have had previous anti-CD38 monoclonal antibody, PI, and an IMiD, which basically everybody has now by second line. But in here in the label, you don't have to have 4 lines. Now, the investigators in the DREAM2 study upon which this was approved used 2 different doses, but ultimately came up with 2.5 milligrams per kilogram every 3 weeks as the recommended dose going forward for FDA approval. And it should be noted, and you'll see due to the data, that there are ocular toxicities that are important. And because of this, there's a mandated risk mitigation program, or REMS program, to monitor for ocular toxicity and potentially change dosing, either dose amount or frequency for these patients. So you can see patients in this study were very heavily pretreated, prior lines of 7, median prior lines of 7 in the 2.5 milligram per kilogram group. And here you can see overall response rate was 32%, but the duration of response. So if you do respond, you respond for 11 months, which is kind of what we saw in cevostamab and what we've seen in actually a lot of studies and even some CAR T studies. So it's the likelihood of responding might be less than what we've seen, but the patients who do respond do okay. I think the main toxicity to look out here for is keratopathy, which is 71 to 72%, but grade 3 or 4 at 44%. Now, just because you have keratopathy, which sometimes is these microcystic epithelial changes on the cornea, doesn't mean you have actual decreased visual acuity or symptoms. And in fact, some of these patients are just noted by slit lamp exam to have this change in the cornea. And that's what ultimately clues the investigator or the physician to change the dose through the REMS program. But the patients are not actually symptomatic. So really, this is truly a mitigation strategy to try to prevent these visual changes from happening because they can be uncomfortable to the patient. So again, monitoring these patients requires partnership with an ocular specialist. It can be an ophthalmologist or an optometrist, somebody who knows how to do this exam and report back on a specific form about the keratopathy seen, what it is. And with that information, you as the prescriber can make the decision based on a very nice guidance table that they have to decrease the dose or hold the dose, wait till things recover, and see if you can get the patient through. It should be noted that on the DREAM2 trial, 94% of patients' vision did return to baseline or near baseline. And so I think this idea of risk mitigation and having a formal program is actually very important, because the reality is we aren't eye care specialists at all as oncologists. And that's something I definitely consider myself to be nervous about the eye, because it's just not my field. You know, this drug also has thrombocytopenia, but I feel okay managing that. So I think it's good to kind of outsource this by force to the ocular health professionals. And I've actually found them to be very helpful in these situations. I want to take 2 minutes to just talk about what's going on in this DREAM program. Of course, as myeloma doctors, if it's good one way, why can't it be good in combination? So here's some preliminary data from DREAM6, where they combine belantamab mafodotin with bortezomib dexamethasone with overall response rates somewhere in the 70 to 75% range, even if patients have had prior bortezomib. And then on the right-hand side, you can see some data from the Algonquin trial combining belantamab mafodotin with pomalidomide and dexamethasone. A really nice overall response rates at various different doses, but they do still have some keratopathy with these microepithelial changes. So I think that this is something that has to be monitored and treated appropriately. And probably the best way to go forward with these symptoms is to hold the dose and have a little pause in between the dosing. And I think we're going to learn a lot more how to use that. What I thought was really interesting as going forward and thinking what else can we do with this agent is the DREAM5 study, part of which was presented by Dr. Natalie Callender, a really nice presentation of combining belantamab mafodotin with an inducible T-cell co-stimulator agonist, aka ICOS, for patients with relapsed refractory myeloma. And the idea there is that there is an immune response enhancing sort of activation. And if it's possible to enhance that immune response more, for example with this drug, faladilimab, I always confuse it. But anyway, it's an ICOS agonist. This might be a way for us to improve the response with belantamab mafodotin on board. Now, DREAM5 has a bunch of immunotherapy combinations, but this particular combination was the one presented at ASH this year. And you can see here, overall response rate was 52%, which is actually pretty respectable for patients with the median prior lines of 5, considering that this is the original data had shown a 30% overall response rate in general. Now, AEs of special interest, which I think here important here is any corneal events. And what is interesting is I think this is small numbers, but it looks like the corneal events were around 60%, which is a little bit less than we saw in DREAM. I don't think there's any particular reason that this ICOS agonist would cause less corneal toxicity. And I think with more patients, it's probably going to pan out to be the same, but at least it's not worse. So I think that's very reassuring data for us. And really, I commend the investigators for trying to think of something novel to try to combine these therapies and get a better response for patients who have so many different, have had so many different lines. So in conclusion, I would say that I love CAR T-cell therapies and I love Ed, but I mean, they're kind of yesterday's immunotherapies, maybe like the Facebook. They're kind of like what your grandma uses and maybe some aunts and uncles are commenting, but there are new new exciting therapies on the horizon, like bispecifics. They are like that TikTok. You can get that all in just a 120-second clip there. Maybe there's going to be off-the-shelf combination therapy off the shelf, like the TRIM data, maybe steroid-free one day. I'd love that. And I think we can get away with that after the first few doses of bispecific T-cell engagers. Unfortunately, no cures yet, and there is no plateau on these curves. But I do suspect that the future is immunotherapy bright, and it's going to come probably second line by 2023. Do not worry. There's always room for more therapies, including cell mods, alkylating agents, and selinexor, as well as room for personalization. I think depending on what patients need, their logistics, et cetera. And you do have to consider these other things like cost, quality of life, which I commend all the investigators. They have this as the PRO data, which I think is going to be important as other outcomes for these therapies and may make the difference between choosing a bispecific versus CAR T. Have to think about accessibility, referral patterns, and logistics. And with that, I want to say thank you. This is our myeloma team in San Francisco. We are very COVID compliant, especially on my birthday, which is the center there. We usually have our Cinco de Myeloma party, but haven't had it in 2 years. I don't know what we're going to do this year. So my colleague Jeff turned 75, and I got to have a party for him. So very excited, hopefully, to see all of you in person someday in San Francisco. Thank you. Okay, so let's go with this post-test clinical vignette. Again, we have our 81-year-old man diagnosed with myeloma with multiple cytogenetic abnormalities, some renal insufficiency, has a history of hypertension, cataracts, and bradycardia, started on RVD, didn't tolerate Rev, so went on to Cybordi, got VGPR, maintenance VD, had progression, has been treated with daratumumab, carfilzomib, elobortezomib, still has progression, has a creatinine clearance there on the borderline 1.38 with a clearance of 44. What is the next best immunotherapy option? So we have isatuximab, belantamab, mafodotin, BCMA bispecific T-cell engager, or BCMA directed CAR T-cell therapy. We'll let you, well, I don't have any music. I should have been singing, but everyone can vote. Thanks, Josh. Is that Scorpions?
Absolutely. It's Rock You Like a Hurricane.
I know. I can hear it even with our high fidelity noise here. Okay. Do I push this or does it get pushed? Oh, here we go. Yes, my job here is almost done. And I just want to explain this. You know, the patient had previously gotten daratumumab, so I wouldn't have picked isatuximab. The patient had cataracts, so I wouldn't have picked belantamab mafodotin. Regarding CAR T-cell therapy, the patient's creatinine clearance was just a hair below what was allowed on the original clinical trials. For apheresis, it was 45, and his was 44, whereas a lot of these bispecific T-cell engager studies allow for patients with creatinine clearance of 30 or more. And I think that's really important for our older population where that is factored into the Cockcroft-Gault equation. So I would have picked C as well. Okay, I think that's it. Now it's time for questions for participants. Do we have time?
No, actually.
There's also.
Sorry.
No, go on, Josh.
No, unfortunately, we're because we like to chat, and I'm going to blame Joe because he's not here for pushing up past time.
I stayed on time, by the way.
You were amazing.
You absolutely stayed on time.
Nina.
As always, Nina, you're perfect. And although we can't see, I'm sure you already did 400 miles today on your Peloton.
I did do my Peloton today.
So really, we just want to thank everyone for tuning in. Remember that in order to claim your CE/CME credits, you need to complete the certificate. You need to complete the online data information and evaluation prior to August 22nd, 2022. And then you will receive your CME for listening to us yammer. Really want to thank everyone for putting this together, specifically Joe McHale, who is off conquering myeloma somewhere else at the moment, Dr. Ed Stadmauer, who is going to CAR-T away everyone, and Dr. Nina Shah, who's going to find anyone who's left to give them a CAR-T and a bispecific. And for those of you who enjoyed listening to us, there is another upcoming program that we have on April 2nd. So if you haven't had enough of myellennials, myelebrities, Nina, are there any new terms that I should introduce everyone to?
Well, the hashtag PFS girl, that's me.
Absolutely. And with that, we want to thank everyone and wish you a wonderful evening.